Hello. In the interest of time, we're going to get started. Today we do have two speakers. The first will be Mary Alice Lavin. So Mary Alice is currently with the Hektoen Institute of Medicine, supporting healthcare facilities in the prevention and control of multi-drug resistant organisms as a grantee of IDPH. So with more than 37 years of experience in infection prevention and control, she worked in a variety of healthcare settings, leading and supporting the efforts to reduce the rise of infection and create a safe environment of care. Mary Alice is has been a member of APIC since 1983 and has been certified in infection control since 1948. And then I'll do them both. The second speaker is Dr. Mahajan. So Dr. Mahajan is the president and CEO of CIMPAR. He is the clinical associate professor of medicine at the University of Illinois Chicago and faculty in geriatrics fellowship at Loyola University Health System. Dr. Mahajan is certified in infection control and epidemiology, and he is the pioneer in developing the PALTC population concept, and has been a leading force behind developing meaningful quality measures for physicians practicing in the PALTC space. His area of interest in research include infection prevention, antimicrobial stewardship, and psychotropic use in the PALTC. So thank you. Please, first will be Mary Alice.
Okay, so I am going to talk to you about infection prevention and control in long-term care facilities. And my subtitle is It's All About the Basics. And I'm definitely a basic person. I always like to go back to the basics. I have nothing to disclose. The objectives of my part of this session are to recognize the importance of partnerships and communication, and to apply the basic infection prevention and control principles in long-term care settings. So building a strong infection prevention and control program will take time, particularly in long-term care. Acute care has been addressing infection prevention and control in a more formalized way for a longer period of time. And so long-term care, don't get frustrated. It does take time to build a strong program, and it does have a lot of different layers to it. And so important to that are these five major topics that I'm going to touch on today. So partnerships, communication, surveillance, core infection prevention and control practices, and stewardship. And so partnerships are extremely important because none of us know everything. And we certainly interact with many others in the work that we do. And so some of the partners to consider are your sharing network and accountable care organization members or partners. So who do you share your residents with? Where do you receive those residents from? Because you're going to want to have a good, strong relationship with them in order to care for that individual in a holistic way. And then your local and state health departments, very important players. And I know that, I guess my view is prior to COVID, we didn't necessarily think of the health department as a partner because oftentimes they're viewed as a regulatory agency. But I think one of the good outcomes of COVID, if there were any, were that there really were stronger relationships built between local and state health department partners and acute and long-term care facilities. And then the Illinois Department of Public Health Regional Infection Control Coordinators, the Hektoen Infection Control Consultants, which I am one of, those individuals from Telegen, which is the Quinn QIO for the state of Illinois, and then CIMPAR, specifically currently in the southern part of the state, they do have a grant for respiratory protection. And so they provide services related to assessing your respiratory protection program, doing train the trainer for fit testing, providing an assessment of your indoor air quality and providing some air purification devices. And then the UIC School of Public Health, which currently has a viral respiratory diseases program that's an extensive educational program and will also assist facilities if they are having a viral respiratory disease outbreak. And so the links to the last three sort of external partners are there for you in case you want to take advantage of some of those no cost to you services. And so I just wanted to share that IDPH now has 7 regional infection control coordinators, and several of them are here today. And so this is a listing. You can find where you come from in the state and then connect that to that regional infection control coordinator. They are here to assist you, to answer questions, to help you problem solve. And they're also available to come on site and perform an infection control assessment. So evaluate your infection control program and provide recommendations. Again, this is at no cost to you. And it is not, they're not regulatory. They are consultative and they're there specifically to help you. So again, an excellent partner that you should take advantage of. And then I use this slide. People who know me know I use this slide whenever I can. And it's actually an archived CDC slide, but I absolutely think it's the best graphic that we could show, right? So we have to work together. None of us are in a silo. And I think COVID proved that to us, right? What happened in one setting spilled over into another setting. So we have to make sure that we work as a team. Most importantly, who's in the center? Public health. So again, this is another example. Public health is key to helping us control and contain transmission of any organism, but specifically multi-drug and extensively drug-resistant organisms. So something very important to keep in mind. So communication. Communication is key to everything we do. It supports a culture of safety, and it includes both internal and external communication and communication with all our partners. So the internal communication involves communication to the staff that you work with every day, but also to the residents, to the families, and the visitors that are entering your building. You want to make sure if there is respiratory disease in the community that you're communicating with visitors and families about how they can help control transmission. So think about those internal communications. And then external communications can involve the local health department, the Office of Healthcare Regulation, because we know it's not good enough just to report to one person. In long-term care, you have to report to at least 2 people if something bad has happened, right? So don't forget about OHCR. And then, of course, the receiving facility. So if you're transferring a resident out for some reason, you need to make sure that that receiving facility knows how to best care for that resident. And then your community partners. So many of the people that I spoke about in the previous slide. Communication isn't just nice. It's also required by the Centers for Medicare and Medicaid, or CMS, as well as the Illinois Department of Public Health. And we're going to talk about in a second some of those specific requirements. And then depending on who you're communicating with and what that message is you're trying to communicate, your communication could be verbal, electronic, and or written. But it's always important to keep in mind what the key information is you want that audience to use or to receive. And so you want to make sure that that information is clear for that specific audience. So this is one example of interfacility communication that is required by the Centers for Medicare and Medicaid. This is from the State Operations Manual. Some people know it as Appendix PP. And this is the section specific on documentation in general. And it does require when a facility transfers or discharges a resident that certain information is communicated. And the information related to infection control would fall under D here. So all specific instructions or precautions for ongoing care as appropriate. And so this is where information about transmission-based precautions would fall into the regulatory requirements. And because the state operations manual is 800 or 900 pages, with the links here, I've included the specific page that I've taken these snips from in case you want to go back and reference them. So CMS also has additional information under the section for enforcement or their procedure for enforcement specific to infection prevention and control under F880. And here is where that language specific to transmission-based precautions is spelled out. It says when a resident is transferred, the information provided to the receiving provider must include special instructions or precautions. Now, when CMS publishes the state operations manual, they use red italics to indicate new language. And so the newest language, and this is from February of 2023, so we haven't seen an update since February of 2023, includes this clarification that transmission-based precautions, if applicable, is part of those special instructions. I would expect that we'll see an update to the state operations manual that will include more specific language about enhanced barrier precautions, which we're going to talk about in a second. So be on the lookout for that. And then the Illinois Department of Public Health also has some recent changes related to communication. And that is in the the notifiable, I'm not going to remember the name of it, Notifiable Diseases and Conditions Code, formerly known as the Communicable Disease Code. And so under the new edition for multi-drug resistant organisms of epidemiologic importance, there is a requirement that the healthcare facility shall confirm notification to a receiving facility before admission or transfer and include admission and transfer orders if the patient/resident is positive for an MDRO, or if the patient was screened or tested for an MDRO and the results are pending, and make notification once the test is completed. So those of you that were in the room from the previous speaker, we already have this requirement in the state of Illinois. It's new, it's just since February. So maybe a take-home exercise for you is to go back to your organization and find out if you have obtained a culture before you transfer a resident out to acute care, how are you communicating that result? Most likely the burden is going to be on acute care, because if you're transferring someone out because they look sick, you're not going to stop and collect specimens. You're going to transfer them. The ED is going to collect the specimen. And so then it'll be their responsibility to implement this to make sure once that culture is finalized that you are notified. So this is where the partnerships come into play. Talk to your acute care facilities, as was suggested. Talk to the emergency department in the facility that you most often receive residents from, or talk to the continuum of care coordinators. Your liaisons might want to talk with them to find out what that mechanism looks like. Who are they going to call? How are they going to notify you if they've collected a specimen, they've placed a resident on antibiotics, and then they've transferred that individual back to you, so that you don't get into a situation where someone is being treated with the wrong antibiotic. So we have been having these regional roundtables throughout the state. We have held 9 roundtables, and part of the goal of these roundtables was to improve communication, particularly at transitions of care related to infection prevention and control information. And as a result, we have modified the CDC interfacility transfer form based on the input from these 9 regional roundtables. The goal that participants gave us was to create a one-page form. And so we took the information from each of these roundtables and created this one-page form. Now, this is a completely voluntary form. There is no IDPH requirement to use this form. We would encourage you to use the form, but if you already have some other system in place that allows you to have that information exchange seamlessly, then fine, continue to use that. But if you don't have a mechanism, this tool is available on the Hektoen webpage, and the link is available here, and we would encourage you to utilize it. Some of the feedback that we got was specific to were there cultures pending at discharge. So again, to help facilitate that communication with information specific to the care of that resident. And if they were on antibiotics at that transition of care, what is the reason for that antibiotic? So again, contact information for the infection preventionist at the facility, as well as the transferring unit nurse. So a free tool for you to use, not required by IDPH, but we certainly recommend using this tool or some other form of standardized communication at transitions of care. And then interfacility communication, again, a CMS requirement, and that is that it doesn't just occur at the time of transition, but also then within the facility. So if the long-term care facility is receiving a new resident, it's important that there is a system in place at that facility so that communication about infection prevention and control place within the organization. And it can't rely only on the director of nursing, the assistant director of nursing, or the IP, because they're not there 365, 24/7. So it has to be a system. It can't be a person dependent process. So again, something to think about. And then a tool specific to Illinois that can be used for communication is the extensively drug-resistant organism registry. Again, very unique to Illinois. I think it's one of the only, one or two, Angela, two in the country. And it is meant to be a more efficient way to communicate between facilities when an individual has an extensively drug-resistant organism. It helps support surveillance and tracking, not only within your facility, but for the local health department and the state health department to have an understanding of where across the state, where across the specific jurisdiction you're in, these extensively drug-resistant organisms are occurring and if they're increasing or remaining stable. There is a mandatory, not only a mandatory requirement to report into the registry, which has been in place for many years, but now with that same February update to the Notifiable Diseases and Conditions Code, facilities are also required to query the registry. And so here is the specific language about querying. If you are a facility that receives automated alerts, that meets this requirement. Unfortunately, long-term care does not receive automated alerts yet. Now, there is a pilot study that is being conducted with some long-term care facilities. The hope is that that pilot will be successful, and then the automated alerts will be also implemented in long-term care. This would allow you then to just receive that communication from the registry and not have to physically go into the XDRO on a daily basis and compare it against any new admissions that you have received to identify someone that has an XDRO. And so surveillance is also a very important component of a strong infection prevention and control program. It must be routine, ongoing, and systematic, using standardized definitions. And it should be based on your facility assessment and the population at risk. So you need to know who's in your building, what risks they have in order to help you decide what you're going to follow. If you don't know what's happening in your building, you can't control it and you can't contain it, and therefore you won't be able to improve. Surveillance includes both outcome and process measures. The outcome measures include your healthcare associated and community acquired infections. And it should address not only infection, but also colonization. Process measures include adherence to core practices, which I'm going to touch on in a second, as well as compliance with policies and procedures. And then it really doesn't do you any good if you do all of the surveillance, if it's not documented. Oh, someone gave me a message. I have 5 minutes. That was kind of special, whoever did that. Document that surveillance data so that you can analyze it and report it back to your administrative staff, but most importantly to your frontline staff, because your administrative staff likely is not who most often is providing direct care and can impact those outcomes. And so anyone who works, who watches or listens to the Friday webinars, this slide you're probably tired of seeing, right? And so these are the core infection prevention and control practices that Deb talked about, probably ad nauseum, right, during COVID, that we still like to focus on because they are the core practices. And so I am going to focus on enhanced barrier precautions. So quickly, this is the timeline of how enhanced barrier precautions was presented. The CDC released enhanced barrier precautions in July of 2019. CDC and HCPAC then met in November of 2019, and then the world stopped, right, in March of 2020. HCPAC issued a document in June of 21, but we were all very busy. CDC released updated guidance in July of 2022. And IDPH had the first webinar on enhanced barrier precautions in September of 2022. IDPH then released a guidance memo in June of 23, and then a toolkit in February of 2024, just in time for the QSO that came out on March 20 of 2024. And so just as a refresher, or if you're not familiar with enhanced barrier precautions, this is the first document CDC released and instructed us to consider the use of enhanced barrier precautions for residents with wounds or indwelling medical devices, regardless of their MDRO colonization status, and also for infection or colonization with an MDRO. So the toolkit is very comprehensive. It includes a background information that also spells out the differentiation between multi-drug resistant organisms and extensively drug resistant organisms, because CDC does not use that term. That's an IDPH specific term, XDRO. It provides resources for the registry. It includes algorithms for transmission-based precautions in general, and a table for resident room placement, so to help you guide if you have to cohort. Links to the CDC signs for transmission-based precautions, including enhanced barrier precautions, a tool for selection of the ideal surface disinfectant, and then a lot of training materials, including video, PowerPoint, and an exam and attendance documents that can be used for your training. And so again, I just want to point out that in the IDPH toolkit, there is specific language about XDROs and MDROs. And CDC allows states or jurisdictions to implement based on what they see in their geographic region. And so that's why Illinois has differentiated XDROs from MDROs, because we have a higher burden of many XDROs than other states in the country. And so quickly, enhanced barrier precautions is both pathogen-based and risk-based. The pathogen-based approach, it should be used with residents with XDROs unless they have draining wounds that cannot be contained or they have diarrhea. For MDROs, the resident's clinical situation and the prevalence or incidence of that particular MDRO in your facility must be considered. And this is when your facility risk assessment is very important. You need to know what normally is in your building or the organisms that you normally see in order to decide if this is something that is more prevalent in your building or it's an organism you've never seen. If you've never seen it, then you might want to consider placing those residents with that organism on enhanced barrier precautions. The risk-based approach is just that. It's based on the resident's risk for acquiring an MDRO, an XDRO. And it is used unless contact precautions is required by CDC's Isolation Precautions Appendix A. It's used for any resident with an indwelling medical device, unless contact precautions is required, irregardless of whether or not they have an XDRO. And always standards precautions is utilized. And so thinking about the pathogen-based approach is a containment and control measure, and the risk-based approach is a protective or preventive measure. Standard precautions always used when you anticipate blood or body fluid or secretions or excretions exposure. And so for contact precautions, a private room is required. Room restriction, this is a change from what you all have done in the past prior to enhanced barrier precautions. Gown and gloves are required just to enter the room. Dedicated equipment, resident targeted based on the organism, and it's time limited, and you need to make sure that your care plan reflects that. If you put them on contact precautions, you need to indicate in the care plan when that will be discontinued. For enhanced barrier precautions, they can be any room. They're able to move about the facility. Gown and gloves are required for high contact activities. Shared equipment, obviously cleaning and disinfecting between resident uses. It's broadly used across the facility, and it's used for the duration of stay or until the resolution of the wound or discontinuation of the indwelling device if it was a risk-based approach. Whoops, I'm back up. This is just the QSO from CMS, which came out in March, saying that now state survey agencies will survey for enhanced barrier precautions. And so I'll end on stewardship. Stewardship is the careful and responsible management of something entrusted to one's care. And we are all entrusted every day with the care of residents and patients. And so we are all stewards. Stewardship can take many forms. Financial, we need to make sure we use our resources wisely. And so doing a cost benefit analysis, we heard a little bit about cost benefit in the last presentation, to ensure that you're spending your money wisely. And then diagnostic stewardship, we heard also a little bit about that. We want to eliminate unnecessary testing, improve diagnosis and treatment, making sure that the right test for the right resident prompts the right action. And then antimicrobial stewardship, which we've heard about all day today, optimizing our selection and dosage and duration of antimicrobials. It is a CMS requirement, so keep that in mind. And then it is a resident safety focused initiative. And so with that, I will turn it over to Dr. Mahajan. Thank you.
No. I'm not. And that wasn't, it was the only thing that should have been in 5 minutes. So you were fine on time.
Hi, everyone. I'm back. So we gave two spreadsheets. There's a small one and a big one. We'll start with the small one. We'll jump right in, and this is something we have done. So it might be a repeat for a few of you who have attended our sessions recently, and there was a lot of good feedback, but I know several of you have not seen this. So we're going to do some actual work there's a power in looking at data and then getting your hands dirty. We have a lot of softwares out there. We have control modules, we have stewardship module, we talk about BCC matrix care, all of that. And we throw a lot of terms. And so just in a rapid fire way, hopefully we are able to do 4 things today by looking at these spreadsheets. All right, I'm gonna need some volunteers, and if I don't, I will volunteer. So just ask for a few definitions here. So we're gonna start with what we call prevalence. Okay, so when stewardship came around, really a lot of it is, can we track antibiotics? Right? Do we know how is the antibiotic use going on in our buildings, right? And so, and then we realized that some of that data is in the EHR where the physician or the practitioner orders go in, but then a lot of time dispensing data is in the pharmacy, EHR pharmacy system, which is not connected. And in hospitals, it's a single database, right? And so does the antibiotic orders tracking give you the right antibiotic administration? And the answer is probably not. So a lot of the information probably lies in the pharmacy system. And do we have access to that to track our antibiotics, right? So, DOT, AUR, and AS are the 3 terms we use. DOT is days of therapy. Very, it's self-explanatory. AUR is antibiotic utilization ratio. And then AS is antibiotic starts, right? And so, and those are technical terms, and a lot of times if you need weeks, months, days of data to be able to get to it. And so recently, a concept of can we do what we call a point prevalence, right? Can we do that to, when we start to get some of the burden of antibiotic use within the facility, can we get to that first while we put our proper stewardship program together and track those DOTs and AURs, and then we'll get to that soon. So any volunteers to define prevalence? What does prevalence mean? All right.
Amount of something present.
Amount of something present of the population. Okay. Anybody else want to be a little more sophisticated than that? Right.
Like new and ongoing existing, like diseases.
New or ongoing existing diseases, right? Okay. Anybody else? Are we on the right track? All right. So, I'll say what the definition of point prevalence is, right? So there's a point and prevalence, 2 words we're using, right? So, right, do you have? Okay.
I think the difference between prevalence and incidence is new cases, prevalence is overall.
So we're just talking about prevalence, right? So we're not
Overall cases.
okay. So overall cases, right? So there are 2 elements that we call point and we call prevalence. Right? Prevalence is, if you see the English meaning of it, is presence. And point is time. So in a given point of time, if what proportion of the population has a certain condition, right? So prevalence could be of a disease, prevalence could be of antibiotic use, prevalence could be of a complication, prevalence could be anything, right? So here we're talking about point prevalence of antibiotic use, right? So that would be then, can we tell for the point, which could be a day, a week, a month, right? We can, but not longer than the point. Otherwise, it'd be too broad. So for a given point of time, a lot of time, which is a week or a month, how much antibiotic we're using, and that's how we calculate. So if you look at your first face sheet or the spreadsheet, Is it a different presentation? In the same? So, if you look at the first, spreadsheet, and I'm sure you're not from Shady Pine Nursing Home, so, that's a created, database, and so it's not actual database. And so if you look at this, we are looking at the data from, first week of January of this year at Shady Pine Nursing Home. And the question we're asking, can you calculate the prevalence of antibiotics for the new admission for the first week of January at Shady Pine Nursing Home? And whoever's done first can raise their hand and let me know what you think. And if you're done calculating, I would also like you to just take a look at, I mean, you have the same spreadsheet with you. There are 3 or 4 things an infection preventionist, a physician, a nurse, a pharmacist should look and say, you know what, that doesn't sound right. And that's your eye as a clinician who's been practicing in the field, whether you're a nurse, whether you're a pharmacist, whether you're an infection preventionist, administrator. And I like to have, if anybody looks at this spreadsheet, say, you know what, that doesn't sound right.
30%.
30%. Okay, all right. Has anybody come up with a different number? 20%. Okay, that looks like one of those auctions. 30%, 20%. Any lower, 10%. 30%. Okay. Anybody else? A person who came up with 20%? Anybody else? How many people say it's 30%? How many people say it's 20%? Okay, so there's still a lot of people don't know what that is, right? So, all right, so let's table that for a second. By looking at this data, is there anything that jumps at you? Six out of 20 are on antibiotic, and thank you, that's how we calculate it, right? What else? When you look at, just go at all the different rows and columns. There are a few things. Okay, go ahead. Dr. Smith. What about Dr. Smith? So Dr. Smith has every single antibiotic out of all the doctors, Dr. Smith. So what's wrong with Dr. Smith? Now, these are tricky things. Is there anything wrong with Dr. Smith? Why? Right. So if you could say, well, there's something wrong. Dr. Smith got all the antibiotics, but remember, these are admissions from the hospital. So Dr. Smith has nothing to do. These people came in on antibiotics. All right, we got one more raised hand. Yeah, sure.
Isn't a doctor because 3 out of 6 patients, so it's a good ratio between short and long-term residents.
Okay, all right, great points. Anybody else, any other comments? Go ahead.
Hello. What I noticed is that indication, antibiotic indication is not listed for some residents, some patients.
So again, power of observation. So there are a lot of those, the residents that have no indication are not on antibiotic, right? So there are residents that were admitted, but they were not on antibiotic. But if you look, that's a good observation. But everybody with antibiotics does have an indication. All right. Okay. All right. So the prevalence. Okay, go ahead.
For the diagnosis of cellulitis, always doxycycline is the antibiotic given. So there may be another antibiotic.
Okay, all right. So there looks like a pattern of doxycycline being used for cellulitis. Very great observation. What else? There are a couple of, I'll say, okay, go ahead. There are females that are being prescribed antibiotics, okay? All right, so let me ask a few more questions before we do the calculation, and then we move on. So question number one, do we from our several lectures on appropriate antibiotic use, do we see something odd on the diseases that are being treated and the antibiotics being used? There's a use of clindamycin, correct? There's use of a quinolone for UTI, right? There's use of a macrolide that is not really the true indication for pneumonia. So there's a lot of those things. So just good observation as infection preventionist of this data. Okay, all right. How about the units? Any patterns there? Yeah, quite a few people on unit A.
Yes.
Okay. All right, so. Okay, we're gonna do the calculation. So the prevalence of antibiotic in new admission would be all the people who got admitted on antibiotic divided by all the new admissions multiplied by 100 because it's a percent, right? Okay, let's see if we did it right. Number of residents on antibiotics. Total residents in a facility multiplied by 100. So that's 30%. All right, okay. So the answer we gave was prevalence of antibiotics in the new admission in the week. If I ask you, can you calculate the prevalence of antibiotic use in the facility? Can you answer that question with the data that you have? Look at the spreadsheet. Why?
We don't even know how everybody is. There's 100 people, we got 20.
Okay. So there's not enough data unless you tell me that these are the only people on antibiotic and none of the existing residents are on antibiotic. We cannot calculate that, right? So this is the data only gives you antibiotics for the new admission. And if you were to use point prevalence of antibiotic at the facility, there's not enough data. Although we know how many residents we have in the facility, we know we have. Okay, all right, good. Days of therapy, or what we call ratio of days of therapy. How is that calculated? Volunteers.
Days of therapy divided by, total census times 1,000. Is that right?
Okay.
Or like,
Say that one.
the days of therapy divided by total patient census times 1,000. Is that how you get the percentage? I mean, is that right? I don't like that.
All right, neither do I. Okay, we are not alone. Anybody else? Days is called, the question is ratio of days of therapy, which I am hoping a lot of you are reporting regularly. Right? And so automation is good, having data inside the system is good, but I think it's really important if we get to know how the sausage is made. So we're gonna get to this, is the bigger spreadsheet. And again, I would like everybody to look at this and you have it with you. And again, make some comments. Do you see this? Do you get this in your facility? And we're gonna calculate those three things. We're gonna calculate ratio, days of therapy, or DOT. We're gonna calculate AUR, which is the antibiotic utilization ratio, and we calculate antibiotic starts, right? So now, days of therapy and antibiotic starts are very, very self-explanatory, right? Right? So antibiotic starts, number of new antibiotics that were started at the facility. Days of therapy is the number of days therapy was done, but a way to calculate the actual measure, and that is per 1,000 resident days, right? Those two numbers, antibiotic starts and days of therapy, is measured, standardized across the system as per 1,000 resident days, right? And so we're gonna calculate that, but before we calculate that, you look at this spreadsheet, this is the data you get. Just look at it and see, is there anything that, again, stands out that you want to make a comment on? If not, we're gonna jump right into calculating those three things. So Avery Miller is on extensive antibiotics, okay.
Just said that the first one's on the level for prophylaxis.
Right. Yep. It's not, it's worth observation. It is an antibiotic. So if trimethoprim, sulfamethoxazole is bacteria, then it could be appropriate. Yeah, but there's only trimethoprim. Avery Miller, someone mentioned, is on long antibiotic, and it's but if you look at it's for 30 days. It's for that month, and it's on vancomycin and gentamicin, and the indication is endocarditis, and a lot of times endocarditis and osteomyelitis conditions where there is a 6 to 8 weeks therapy, so it could be okay. Anything else?
So, yeah, that was Miller on therapy, ceftriaxone and medicine.
Okay, and again, that sometimes could be a true in a hospital condition and non-common condition, it could be appropriate combination for treating antibiotic. Okay.
Is this oral or free? For Casey Taylor.
Mitronidazole for Casey Taylor. The question if it's oral or is IV.
Oral or free? That's a free.
So these are systemic antibiotics. These are topical. Yeah. If it's appropriate for cellulitis, good question. I don't know. I just have the data. But good. We need. No. This is good exercise. Are we able to look at things and question? That's why we are here, right? Okay, good. All right, let's do the first calculation. The ratio of days of therapy. What is the formula? Total number of antibiotics divided by number of residence days multiplied by 1,000. Okay, so what's the answer?
Is it total number of antibiotic days or total number of antibiotics? Because is it total number of days on an antibiotic or total number of antibiotics? Because if there's one of them where you have to, which one was it? There's one of them that started and you're not gonna complete it or something like that. And you have to like modify whatever you're doing. Because I did 88 days, which I don't think that's correct.
All right, so okay, maybe you can ask that question a little more.
I am going with 106 days of treatment, so like treatment days divided by the 100 resident population times 1,000.
All right, okay. All right, anybody else? So I think the question being asked is, are we using the days of antibiotics? Are we using the residence, right? So the question is, for each day, each resident is on 2 antibiotics, is that 1 day or 2 day? And that's why we are here, right? So we are a lot of experts in this. Go ahead.
Yeah, so we counted that there was 143 days of therapy, and there was 3,000. If we had 100, but then we times it by 30 per month.
So this is December. So-
Oh, okay.
Okay, so the details matter. Okay, good. So I have 88, I have 106, I have 143. 105. All right, we're gonna do a calculation. Everybody look at, you can either look at the screen or you can look at your spreadsheet, it's fine. We're gonna do 7 plus 14 plus 10 plus 10 plus 10 plus 5 plus 5 plus 60 plus 5 plus 7 plus 10. 143. Right? 143 divided by 3,100 multiplied by 1,000. Okay? That's your answer. And the answer is 46-ish per 1,000 residents. Right? They'll come up on this. Just, okay. What is antibiotic utilization ratio? It is exactly the same thing, but it is not per 1,000 residents. So it will be 0.046, right?
Yes.
So that would be AUR, and AUR is how CDC measures antibiotic use as one of the data elements. Although in our reports, we do antibiotic. Now, is anybody having trouble following where we are so far for the days of therapy? I would rather have days of therapy and antibiotic starts hammered down before we leave the room. So is anybody still struggling with days of therapy calculation? Raise your hand, there's not, I mean, go. So we calculate a day for each antibiotic use, not each person. We have 2, right? For 30 days. Okay. All right. And does anybody still have a, okay, we have an HM in the back.
For the start of the antibiotics is, like, it starts like in the afternoon. It is only like the item sample. So do you count it as the first day right away? Not on this, data, but, just, in general?
Yes, yes. Even if there's one dose, that day is counted.
Okay.
Yep. All right, so looks like we're jumping to antibiotic starts, but before we do that, can we make sure, is there anybody still having questions on days of therapy? All right, go ahead. Sorry. How do we come to 3,100? So if you look, the daily census is 100, and we're talking about month of December, there are 31 days, right? 31 multiplied by 100, so 3,100. All right, any other questions on days of therapy? Okay, there's a question. That's what we just calculated that, right? So I just want to make sure that. So the 2 people that are on 2 antibiotics, each antibiotic is counted separately, not each person. All right, so this is important because it could really impact how you're doing that calculation, given you're the leader in the facility reporting that data. These little details are important. All right, so we have one more question.
Is over to a month and months, it's hard to calculate that. Let's say you started at 30, you know, at.
Per day. Now the start will not carry over. The start is that one start of that course, right? And so, all right, so we're gonna, anybody else still having questions on days of therapy? So I can give you another spreadsheet that I'm hiding, you can do that calculation? All right. Okay, so antibiotic starts. All right, now go ahead. Same thing, number of new starts divided by Total number of resident days multiplied by 1,000 is how you calculate antibiotic stock. All right. All new stocks divided by total resident days, because it's still the month of December and census is still 100, it's 3,100, and it's multiplied by 1,000. So if anybody's out with the answer, you can raise your hand and tell us where you are. Okay.
Sorry. 4.2.
The answer is 4.2. No, the proposed answer is 4.2. We're not even going to really yet. Because it's not the answer, it's how you got to it. That's important, right? So, okay, go ahead. No. Okay. Okay, what's the numerator? Which is the new antibiotic stocks. What's the numerator? 13. All right, let's see. Is the answer 4.1? 4.2, yeah, that's what people are saying. Okay. Okay, all right. Let's just do this. You said 2 point? So this is your all right, so why is this different than what people are saying? Look at your sheets again. All right, so we can definitely go home knowing that we learned something today, right? So now for people, antibiotic starts. The numerator comes from the people that got started at the facility. Right? So people who came from.
I don't like that. That's very tricksy. Very tricky.
Right, so that is, the numerator there is. One, two, three, 4, 5, 6, 7, 8, and then the one person. So these are the things you gotta pay attention to, right? So there's, yes, go ahead.
What about when you start an antibiotic and it changes to a different antibiotic? Do you count that twice?
Yes, we do. Yes, those are 2 courses and 2 starts. And even if it's the same antibiotic stopped and started again a week later, we shouldn't be doing, but we still do because we keep repeating cultures. Every time you start, it's a new start. Okay. So, questions?
Are we counting from the ones that just say that we took to the hospital?
You don't count that. People that were admitted to the hospital from the hospital of antibiotics go in days of therapy, not in antibiotic stops. Yes. We are still calculating them. They're still in our data, but they are under either the antibiotic days of therapy or antibiotic utilization ratio, but not in starts. Right? So this is where we are calculating a lot of the facility-acquired infections, things like that. So we want to be tagged appropriately for that. Okay? And why is it 9, not 8? Because there was one person started on 2. So are we good? So 9 divided by 3,100 multiplied by 1,000, and the answer is 2.9. Did we learn something today? All right, good. Okay. Mary Alice, you wanna come up? I think that's good for the calculations. Thank you very much for participating. We're gonna have both of us come up and however long we have, we can take questions or you can take a break. Okay. Questions? All right, thank you very much, guys.
Yeah, I'm sorry, I have a question.
Yes, go ahead.
So, that I struggle with, I've done effective prevention for a while, and one of the things I struggle with is finding data, not just to compare my facility month to month and year to year, but compare it overall to other facility data to see where we stand in other facilities, to make sure that, you know, we're at least kind of at a threshold where we want to be. And so right now I can really only do it based on my facility where we were the previous months and the previous years. Is there anywhere where we can find that?
So very, very, very important question. And when you start asking questions like this, that is when we know that this is beyond lectures and that you're actually going in and doing this. And absolutely we have, so the antibiotic use, and so you're really asking for there's a benchmark, right? So are you giving us, like how much antibiotics should be used, right? And so, to answer your question, there's currently no recommendations from CDC, and we'll come to you on, okay, this is that your BOT be calculated here, right? Is 41.6 or 46, or if the national trend should be 24. Facilities are being asked to self-benchmark, right? And then improve on that. So hand in hand goes what we call the evaluation for appropriateness, right? And so if every month when you evaluate antibiotics and they all are appropriate, then you probably are at the benchmark and you're good, you gotta maintain that, right? And so we evaluate each antibiotic use for the timing, the duration, and antibiotic timeout, antibiotic, all these measures, best practices, clinical guidelines. If you have that established and you're reviewing it every month and all the antibiotics are categorized appropriate, then you're doing okay. But what happens is when you start calculating antibiotic starts and days of therapy, hand in hand, you have your appropriate, so your antibiotic tracking for appropriate use. A lot of times facilities, when they start, they're anywhere between 40 to 60% appropriate use, and your goal is to go to 100% appropriate. Now, not always that happens, but your goal is to be, so for example, Dr. Tran's presentation, we send people for chest pain to ER, they come back and say for plus, right? And so we want to make sure first the days of therapy are appropriate. In that case, you might or might not be able to cut that down, but you definitely want to make sure that all the starts are appropriate, right? When people come from the hospital on an antibiotic with a given duration, a lot of times it is harder for the facilities to review and then stop. Like we have facilities that have done it very nicely, where they have medical directors and infectious disease consultants who will come in and say, oh, I was sympathy. Why yes, I don't need a processing for that, right? We know nursing home residents can have a positive culture, and that is asymptomatic bacteria. We don't treat it just because you culture it, right? So you get to that point, but very great point. The question was, what would do with these numbers, right? What should be my target DOT? What should be my target AS? What should be my target point travel? So a lot of it is making sure that you're doing the review with appropriate use, and that is approaching as much as close to 100.
I have a question, might be more geared toward, if you have a patient with an active infection that needs to be isolated in the urine, is a brief considered it being contained? And can that patient come out of the room into the common area with the rest of the residents? So if you have a patient who has infection in the urine, who is an active infection in their urine, they do wear a brief. Is the infection considered contained, and can they come out into the common area with the rest of the residents?
So the short answer is what does your policy say? Because you're gonna be held to your policy.
So that was my other question earlier. Should our policies mimic public health? Or do they take our policies into consideration during survey?
During survey, your policy should be taken into consideration. So if the surveyor is questioning you, you should be able to state the reasoning why you're doing what you're doing. And that is our policy says because. So if the reason they're on,
May I ask?
Yeah.
So we do have, for folks, if you're listening in, it's good, but we do have break up at sort of 3:45, so if anybody wants to take the bio break, we'll continue the discussion.
so if your policy allows someone who's an MDR or an XDR, because your policy probably needs to define how to care for each type of resident. If your policy says that they can be out of their room and not have barrier precautions because it's continuing to agree, then that's what your policy says.
So the policy.
Your policy should be, right, your policy should be specific enough that you can defend your practice. So.
What if that spills over? I
What do you mean
mean,
by
we've all had residents who are in public urine.
So that would not be, the routine, right? So if an
No.
accident occurred, and an accident could occur with anybody, whether or not they want to get spared. So if, for the most part, the resident can have whatever it is contained, then it can be, if it requires enhanced spirit precaution, they can be on enhanced spirit precaution.
But what if they're being treated for?
So again, that gets to your policy. Nothing in any of the guidance from CDC talks about treatment. Included in the decision-making process for enhanced care.
Isolation.
What's that?
Or isolation.
Correct. So that depends on your policy. Now, we heard when we did the roundtables, many facilities told us that they prefer to keep someone on, either contact or enhanced, while they're on treatment. That's your facility's decision if you choose to, but you better spell that out somewhere. Because you could be questioned and you won't be able to defend your practice if you don't have documentation.
Okay, so if the policy is unclear, I need
You
to
could be in
tell
a
them
pickle.
that we will be in pickle because according to the policy, it states that limited movement upon medical necessity. So that's not really saying, oh, if the patient is in the room and about to fall, you give them out.
Well, I mean, you can document it, the way I document it, for someone even who needs quote unquote contact precautions, we've got someone who has mentioned that happens for falls. You can put in your policy that per the medical director, that like collaboration between IP, DON, and medical director will decide who can come out of their room and for what reason. And then if you document that, what can state say? Because you've already covered your bases.
So I also contacted several extent for with local health department. But, this week,
Sorry, two people are talking at once, sorry.
yeah, this, you come across this with like, okay, with more, right? So